Takayasu Arteritis. The primary learning objectives are to review the classification criteria and other clinical manifestations of Takayasu Arteritis, better understand the disease course and outcomes, and to review the current therapeutic approaches. The presentation outline includes classification criteria, epidemiology and pathogenesis, clinical manifestations, ancillary studies, treatment and prognosis of Takayasu Arteritis. Takayasu Arteritis, or TA, is a rare chronic large vessel vasculitis that predominantly affects the aorta and its major branches. Absence of peripheral pulses has also given it the name Pulseless Disease. The most recent classification criteria are those of the European League Against Rheumatism and Pediatric Rheumatology European Society, published in 2006. These criteria for Takayasu Arteritis include a mandatory criterion of angiographic abnormalities of the aorta or its major branches, in addition to one or more of the following: decreased peripheral artery pulses and/or claudication of the extremities, a blood pressure discrepancy between the arms or legs of greater than 10 millimeters of mercury, bruits over the aorta and/or its major branches, hypertension, as defined by childhood normative data, and elevated acute phase reactants. The American College of Rheumatology criteria are similar, and a patient must possess 3 or more of the following 6 features: bruits, decreased brachial artery pulses, claudication, blood pressure differences of more than 10 millimeters of mercury, younger than 40 years of age at onset, and angiographic evidence of aortic and/or primary aortic branches disease. This sagittal view of a gadolinium-enhanced magnetic resonance arteriogram of the aorta demonstrates a fusiform aneurysmal dilatation of the ascending aorta and a focal aneurysm in the mid-descending thoracic aorta. TA has an estimated incidence of 2.6 per 1 million adults per year, and its incidence in children is unknown. Age of onset is typically between 10 to 40 years, and up to 20% of individuals with TA are diagnosed prior to age 19 years. The disease has the highest prevalence among Asians, though it is distributed all over the world and can affect all ethnic groups. TA has a female predominance, with an average ratio of 2 to 4 females affected per 1 male. The etiology of Takayasu Arteritis remains largely unknown. There is an association between TA and certain genetic polymorphisms, supporting a genetic component. An association with Mycobacterium tuberculosis exposure has been suggested, though not rigorously proven. Elevated pro-inflammatory cytokines in TA supply evidence of immune system dysregulation. TA has an acute early phase when symptoms may be nonspecific and may include fever, malaise, arthralgia, myalgia, abdominal pain, and weight loss. The diagnosis of TA can therefore be a challenge and can be delayed for several months. Persistent vessel wall inflammation leads to concentric wall thickening, fibrosis, and thrombus formation. Affected vessels may then become stenotic, occluded, dilated, or aneurysmal. Therefore, presenting symptoms at this later stage may be a reflection of the vascular territory involved. As mentioned, later disease manifestations typically represent vascular compromise. Hypertension is the most common manifestation in both children and adults. Headache is the second most common presenting symptom in children, and bruits are also a common presenting feature in adults. Other vascular manifestations include diminished pulses, asymmetric blood pressures, claudication, and Raynaud's phenomenon. Renal failure and symptoms of pulmonary and cardiac ischemia may be present. However, it is only after substantial vascular injury that evidence of hypoperfusion becomes clinically evident. Gastrointestinal symptoms include abdominal pain, weight loss, nausea, or vomiting. Skin manifestations, including nodules or rash, and lymphadenopathy are rare. Ocular disease is also uncommon. A woman with long-standing Takayasu Arteritis died of an intraoperative myocardial infarction while undergoing repair of the ascending aorta. This photomicrograph of a cross-section of the right coronary artery shows intimal hyperplasia and a transmural lymphoplasmacytic infiltrate, indicative of coronary arteritis. Laboratory findings are nonspecific, and there are no diagnostic laboratory abnormalities. Patients may have elevated white blood cell and platelet counts and elevated acute phase reactants, though not always. Testing for autoantibodies is not useful except to exclude other autoimmune disease. Radiographic demonstration of large vessel vasculitis is the cornerstone of both the diagnosis and monitoring of TA. Though the gold standard is conventional arteriography of the aorta and its branches, magnetic resonance and CT angiography are gaining acceptance. Both modalities can provide important information about vessel wall thickness and enhancement. Positron emission tomography has been studied less extensively but may also be used to detect vessel wall inflammation. By biopsy, the presence of intramural granulomas in the walls of affected arteries is also diagnostic. The thoracic and abdominal aorta are the vessels most commonly involved. The subclavian, renal, and carotid arteries are the most commonly involved aortic branches. In the left figure, a conventional arteriography reveals pronounced ectasia of the thoracic aorta in its entire length, as well as stenosis of the left subclavian artery in a patient with TA. Right internal carotid injections confirm the presence of an aneurysm in a patient with TA in the figure on the right. There is limited evidence on treatment owing to the rarity of the disease. Glucocorticoids are commonly used and a mainstay of therapy. Remission can be achieved in some patients with glucocorticoids alone. Additional immunosuppression may be required for those with disease progression or recurrence. Antihypertensive medications may be needed to control blood pressure. Intervention with surgical and endovascular procedures may also be required to restore vascular patency or maintain vascular integrity. Patients with TA are probably at high risk for accelerated atherosclerosis, and lipid profiles should be monitored and treated appropriately. TA is a relapsing chronic disease, and a majority of patients suffer relapses. Up to 20% of TA patients may experience a monophasic disease course. The 5-year survival rate in adults range from 70 to 93%. Long-term outcomes for children with TA are not available, though one series reported a mortality rate of 35%. Vascular complications and related organ damage are the major determinants of morbidity, underscoring the importance of early detection and institution of therapy. In summary, Takayasu arteritis is a rare chronic and relapsing granulomatous vasculitis of the large vessels. Diagnosis requires radiographic demonstration of large vessel vasculitis. Diagnosis is a challenge, but early detection and treatment is critical. Key references: